different projects that I will go into here in just a little while. We also have Ako Kwame, who is our VP of Data Management, and he's going to talk to you about many technical things. And then we also have Lauren Gerard, who is our Director of Healthcare Quality Improvement. So a little about CORHIO. We provide HIE and healthcare quality improvement services throughout the Front Range and also in rural Colorado. We recently just celebrated our 10th anniversary. And with that 10th anniversary, we also joined with the Arizona-based health information exchange called Health Current. And so now we call ourselves a regional organization, and that name is Contexture. So you may have seen some news about that flying around on Twitter and such these days. So CORHIO is an independent and nonprofit organization that is dedicated to serving all of Colorado's healthcare stakeholders. This includes physicians, hospitals, behavioral health, emergency medicine services, public health, long-term care, laboratories, health plans, correctional facilities, communities, and patients. A little bit more about the merger itself. The merger allows us to continue the level of focus and dedication that's already in place with our partnerships, while also working to identify best practices and information sharing across state lines, because we all know that we don't stay in one state. So it's interesting to see this shift to the regional organization. All right. We also recently just went through the high trust certification process. And if you all are familiar with this, the high trust certification status demonstrates that both organizations, so Health Current and CORHIO, that our information systems and our technology processes meet key regulations and industry-defined requirements and are appropriately managing risks to prevent security breaches. So this was a fairly rigorous process to go through that involves 19 assessment domains, including third-party management, password management, access control, and physical security. So a little bit more about CORHIO itself. So CORHIO, by the numbers here, we currently have information on about 8.3 million unique patients in Colorado. We have about 22,000 HIE users and 7,700 providers that are participating. On average, we have about 262,000 patient charts that are accessed in Patient Care 360 per month. And Patient Care 360 is our longitudinal health record, which is a web-based portal that providers can log into to access information about their patients. We also send notifications that are based on a member file to about 7.7 million notifications that are sent per month. And we also have 492 patient result messages that are sent out to EHRs. And that's the notification that I was talking about as well. In terms of connections itself, sending to CORHIO, we have about 78 hospitals that are currently live, and that includes 69 data senders. We also have 14 labs live and 53,000 ambulatory care summaries coming in each month that are being added to the HIE data. So a little bit about our partnership with the state agencies. We contracted with the Department of Healthcare Policy and Financing, also referred to as HCPF, in 2015 to manage the EHR incentive program. And we also contracted with HCPF for the high-tech funds, which was offering a federal 90-10 match to onboard providers to the HIE. So we've had quite a bit of success in that space, and that is now sunsetting. And we're shifting into a different program with HCPF currently. In 2018, we contracted with the Office of Behavioral Health to pilot a program with county jails in which they would have access to the HIE, and they would also have the opportunity to send CCD data to the HIE to populate once the inmate was released from jail. CORHIO also supports the Colorado Department of Public Health and Environment by building out interfaces for both SIS or immunization, send, and query projects as well. And in the next slide, I will speak to this health IT roadmap with our Office of Ehealth Innovation. So the Office of Ehealth Innovation was formed out of an executive order in 2015. They focus on advancing the governor's agenda of saving people money on healthcare. The Colorado Health IT Roadmap itself is the state's health IT strategy and was developed in 2018 with broad stakeholder input to align and focus efforts throughout the state. The Ehealth Commission advises the Office of Ehealth Innovation and the state and helps steer that strategic roadmap efforts. They are charged with the task of leading efforts to coordinate health information technology, advance HIE, and data sharing across Colorado's state health agencies. In 2021, the health IT roadmap went through a rigorous update, and they are now going to shift focus a little to health equity, virtual care, and access to health information. And CORHIO continues to partner with them on all of these important initiatives. At this point, I will pass it off to my colleague, Paco Kwame, to talk to you about statewide identity.
Hi, good. I guess it's mornings there. It's afternoon here in Colorado, so I'll say good morning. Thanks, Heather. So I've got a couple slides. They are somewhat technical, and so I'm going to be giving you guys a lot of information. So I'm hoping to get lots of questions in the Q&A section at the end after Lauren's slide. So first, I want to cover two of the state identity use cases. One of the core tenets of the OHI HIT roadmap that Heather spoke about is to leverage existing technology where possible before investing in net new solutions. And as we all know, new solutions take time to implement and in general create silos of data so that when those silos are up and running, that data then has to typically be integrated with existing data points. And so that usually delays things a little more. This program structure is what led to the partnership with the state of Colorado, leveraging CORHIO's existing matching solution. So they were looking to gain greater insight into the use cases, and that we'll talk a little bit about those later. Next slide. So for a little history, the state of Colorado, like many states, has applications and agencies that are siloed from each other. Some of those applications have been around since the 80s. And as you can probably guess, it would be very difficult to build on top of those, modify, change, delete, to do something with the identities in those state applications. And so that was one of the things that needed to be solved. So next slide. So before I dig into the use cases, I want to just give a high level concept of how identity matching works in the industry. So for those that know about identity matching, this is certainly a 101, but I just wanted to put that out there. So the first concept is probabilistic matching. So this is where you have a single data store with identity information. Next slide. Oh, yeah. As you can see, I think you went one, there you go. As you can see in the example, record A and record B would not be linked in a probabilistic matching system because the data elements don't match up. You've got a different name, you've got a different address, and one record you've got date of birth. The other one you have phone number. With next slide. So the second concept of matching is deterministic matching, or some folks call that also referential matching. With referential matching, there's a centralized repository that sits between the records. That repository has millions of rows of demographic data that's kind of already there, that's being constantly curated and indexed. Next slide. So in the previous slide where we talked about record A and record B, you can see that with referential matching, you're able to see that, yes, maybe Catherine Smith used to be Kat Johnson, but she got married or divorced. And so that information is stored in a centralized repository that has all the additional data elements. And as you can probably guess, CORHIO uses referential matching for our patient identity. In fact, CORHIO started off with probabilistic matching, and when we switched to referential matching, we're able to get a 10% uplift in identity resolution, which is great. It's a small number, but it's good. I think right now we're sitting at around between 95 and 98%, depending on the source of the data. So that's really good for us in Colorado. Both systems have their pros and cons, and so definitely your mileage will vary. But for the remainder of this talk, we'll talk about referential matching. Next slide. No, next slide, sorry. Yeah, so what is it? What's the data flow that we've set up with the state? So CORHIO has what we call our master patient index. It is that referential database that sits on our platform. And so what we've done is that we've worked with the state of Colorado to get those flat files from those legacy systems and incorporate those into our identity matching system. That it's the same identity matching system that we use when we get records from the hospital, we get records from ambulatory clinics, and then we get member files or finder files from organizations who are looking like ACOs or whatever, they're looking to get updates on folks as their data hits our platform. So we then use that same kind of technology for the state system. And what that does is it creates a unique identifier that we then are using to match folks across the multiple state programs that are that are part of this initiative. So one of the things you may ask is kind of what happens when updates happen. So with referential matching, we have we receive updates all the time. And so what we do is we then synchronize our IDs with the state, who then pass that along to the various programs. So it's a really good system. It's been up and running about 8 months now, and we'll dig later in a few slides at some of the work that we were able to do with that. Okay, so that's the use case one. The use case two is eligibility analysis. And so for this use case, we wanted to talk about how the system was used for like a one-time proof of concept for eligibility analysis. We did a pilot with the state to demonstrate how this technology could be used. And as most of you know, in general, if you are eligible for WIC, you are, depending, at least in Colorado, you're eligible for Medicaid. And if you're on Medicaid and pregnant or have kids under 5 years old, you're generally eligible for WIC. And then lastly, if you're on SNAP and pregnant or have kids under the age of 5, you are also eligible for WIC. And so in Colorado, all three of those agencies are separate. They have their own systems. And so what we wanted to do as a pilot was to be able to look at the data files or the identity files from all three of those systems and see what we could find out. And so next slide. So here's what we're able to determine after we ran those demographic files through each of those programs through the identity solution. In total, we processed a little over 1.2 million records across the three systems. We found 37,000 unique records across all three systems, with the majority of those records, 28,000, belonging to the WIC program. There were about 2,090 individuals that were getting SNAP and WIC benefits, but were not on Medicaid. Finally, there were about 34,000 identities where folks were getting WIC and Colorado Medicaid, but they weren't getting SNAP benefits. The takeaway here is that by using a centralized identity system, we're able to help the state narrow down the list of individuals who could potentially be contacted proactively to receive benefits that they may be entitled to. Now, of course, there are other factors that are involved in WIC, SNAP, and in this case, HICPA for Medicaid. But if for the 2,090 individuals who are getting SNAP and WIC and weren't getting Medicaid, more than likely that would be a list of folks that you would want to be really interested in getting access to or contacting to make sure they're getting the benefits that are needed. Now, of course, there's another long story about, okay, well, who does this contacting? Who does the work? It is definitely data, and of course, it needs to be actionable. And so the real question is who's going to be doing that work. But at least from an identity resolution standpoint, we're able to take a look at the three files and give them a few metrics. So next slide. So I want to talk a little bit about COVID-19 and identity resolution. What you're seeing here is a de-identified screenshot of a COVID-19 immunization dashboard that CORHIO is partnering with a few other HIEs on. If you think about HIEs in the traditional sense, we take clinical data from multiple systems, hospitals, labs, imaging centers, et cetera. We then identity manage those records and then create that longitudinal health record for an individual, no matter where they've accessed care, provided that that data is being sent to the HIE. When it comes to something like COVID, the COVID vaccine, where an individual could potentially get the first dose at their primary care provider office and the second dose at the pharmacy, and now they may get a booster shot at a totally different facility. The good news about the COVID vaccine is that most states require all vaccines go to the state's immunization information system. However, if you remember what I talked about earlier in the presentation, most of those legacy systems, immunization systems in this case, use deterministic matching as opposed to referential matching for their identity resolution. So there may be an opportunity to leverage a state or regional HIE or similar organization, provided they have the capability to assist the state in providing identity resolution services for COVID immunizations. Next slide. Here is another de-identified example of what CORHIO is doing for COVID testing. COVID testing has a similar need for identity resolution with a bit of a twist, because in general, most states are set up with are not set up with an existing system like they have with immunizations. And of course, there are people who have had, by this point, 10 or 20 COVID tests, right? Across many different testing sites. So now the ability to dedupe and reconcile these identities across multiple testing sites is another use case for identity resolution to make sure that you get the most accurate information. So in summary, next slide, thank you. CORHIO's expertise in the Colorado healthcare market coupled with Verado. So I didn't talk about Verado too much. Verado is a vendor that we use for our referential matching solution, has yielded a very nice tool, and it's specific for our community. Our patient matching is an established standard and does not change based on the information we get. So it is very stable and it's very consistent. CORHIO's population is about 5.8 million, but our MPI has about 14 million and growing lives. And that's because, there are folks come here to, for example, recreate and they go too fast down the slopes and end up having to access our healthcare system. And so there are folks that come through. And of course, Colorado is a regional hub for some of the surrounding states. So people come here for procedures and then they go back to their originating state. So it is a very large MPI, and we're very proud of it. And so it was a pleasure to use the system for the state of Colorado, and we definitely plan on expanding it a whole lot more. So, excuse me. With that, I'm going to pass this along to Lauren Gerard, and Lauren, take it away.
You have a ton of content coming at you today, but I am happy to be here. So I am going to talk about ECQM. So if you don't know what that means, it's electronic clinical quality measures. We have been going through a series of different projects for the ECQM world. And starting out in 2018, we were a part of a CMS-funded program called the State Innovation Model. Through that program, we had 30 eligible practices. We were able to report on 9 of them in a short period of time. So that was really proof of concept through our initial deployment and then our selection of vendor, where I will talk about them a bit later, but we are currently utilizing Diameter Health. As of this month, we have successfully reported 85 different practice sites with our ECQM registry data, and we're actively working with 142 additional sites, and that's spanning across 34 different EHRs. And we're also working with 4 ECQM sites for Primary Care First. So Primary Care First is a CMS Medicare alternative payment model. And through that program, you do need to be a qualified registry with CMS to report, of which CORHIO is currently eligible in that program. Currently, our primary funding on this program is through the Medicaid alternative payment model. So Heather mentioned earlier the Colorado Healthcare Policy and Financing, otherwise known as HCPF, is funded through CMS. Medicaid APM model has a lot of similarities with QPPs. So practices select from a variety of ECQM measures, structural measures, and claims-based measures. They have to get a certain number of points to avoid a 4% penalty on their Medicaid payments. HCPF did acknowledge that ECQMs can be a barrier for practices to report on, and so has partnered with CORHIO and a couple other organizations within Colorado to be able to support all of those eligible APM practices should they so choose. So we're working with those practices, and then I mentioned on the previous slide, we are a CMS qualified registry, so we can report for practices for the QPP or Quality Payment Program model, or we can also report for any Primary Care First practices. Talking about our solution, so as a health information exchange, we wanted to see if we already have data coming in, how can we use that to aggregate ECQMs? So the route that we've gone is we are utilizing continuity of care documents from the outpatient clinics. So we have multiple different feeds from each of our connected sites. From there, we're actually able to aggregate the quality measure data elements into our using our platform, Diameter Health. With that, we're able to calculate the measures, we're able to give them details, we're working through multiple different technical assistance items on that. The other benefit for our participants utilizing this mechanism, if they're also eligible for the Quality Payment Program, the new measure for the being bidirectional with an HIE for the promoting interoperability measures for QPP, that is also going to give them those bonus points and move to attestation versus the really hard health information exchange measures. Talking about technical assistance, so ECQMs are really hard. Practices don't necessarily have a great understanding. We're actually working with a lot of lower level new to ECQM. And so what we're doing is we're working with them with the vendor. We're making sure they understand the measure. A good example with this would be with the adult BMI measure, CMS 69. It is BMI and follow-up. So meaning you have to take the BMI for a patient at least once a year. And then in addition to that, if it is out of range, you have to have a follow-up plan documented. Discrete fields are definitely king when we talk about ECQM. And so the follow-up plan usually goes in a non-discrete field where it's not captured. So I often go into practices and they'll say, we do BMI and we do follow-up on every single patient. And what we see is about a 30 to 40% rate. And that's just because that's what the typical BMI normality range is. And so then we start to work with them on how do we document that follow-up plan in a discrete field. So again, that goes towards working review of those ECQM definitions and then also evaluating those workflows. The other big factor that these practices have in working with us is we provide that data validation. So making sure that you have trusted source of data and also the APM project, we do actually go through audits. If practices choose to utilize CORHIO, CORHIO will stand behind the data and complete all of the audit documentation pieces that are required. So talking about those registry benefits, so we do give up-to-date quarterly reports. We do have some practices requesting that on a more frequent basis, but we're able to provide that patient-level detail. So if I run a report for you today, you will have a report up to the minute that that report finalized. So if I call a report now and you were able to put it in your 12 o'clock visit, with a completed note by 12:30, then that document and that patient's information will be included in that report. Additionally, we're providing that high standard of validation. We're providing the technical assistance, so not just giving it to you, but how do we improve either the documentation or the process improvement to improve that performance. And then decreased dependence on the EMR. So often we're seeing practices go back to their EHR. We found this validation issue. Can you fix it? And they say, nope, it's right. And they're not really willing to make the effort to make the bug fixes go away. Next slide. So this is a practice that we work with. I'm not going to read that through, but we have had a ton of great support from our practices advocating to Medicaid to continue to show the support and show the value that we're providing to continue that funding. Talking about the lessons learned, ECQM is really hard. CCD content isn't normalized. We continuously are working with vendors on mapping issues, making sure things are up to date, making sure workflows are staying into place. We definitely have a lot going on, but we've learned so much in the years that we've been doing this, and it gets easier and easier as we go. But we also have to have that trusted data, and we have to have that continued commitment to working on the data, improving the data, ensuring that we don't have any bugs, because otherwise when we walk into practices, nobody wants to work with us because they say the data is bad, and we kind of don't really get anywhere. We're also able to do site split reporting, which is a requirement for the Primary Care First program. It's also a requirement on the APM program. And then building trust is our priority. So again, bringing trusted data, giving them good information on, directions to go. We have built out incredible relationships with our participants. Next slide. That's it.
Yeah, and I put it in chat, but it looks like when I type my notes, I switched two numbers around. Our current match rate is 86.8 average, not the 95 to 90. That would be amazing.
I was blown away.
No, 86.8. Apologies.
No problem. Lots of questions coming in. If you don't mind me, I will try to kind of pull through these. And I see, Claudia, you have your hand up as well. Just first of all, I think many of us share my response of being blown away. Have you had the opportunity of working with the state directly? Have you had any with our state, with California? Have you worked with our public health officers or anybody in our state leadership that you know of?
Not at CORHIO, but when I worked for the state of Colorado, and one of the things that we're so excited about in Colorado was that SHIG thing that you have for behavioral health. We actually had a couple of those guys come over and present to our human services agencies, because why reinvent the wheel when all of this research was, and obviously I think the SHIG is specific to California, and there are certain rules and regulations in Colorado that are different, but from a framework perspective, excuse me, it was awesome. But that's really the only work that I know of that we've worked with the state of California. And
Katie Hydorn with Insure the Uninsured Project, we can follow up and maybe make sure that we get that connection or introduction if you all don't mind as a team. I think it'd be great if we make that connection.
Absolutely.
And Katie, I think you also had a question about just in terms of, and Heather, this might be for you, just what was your startup costs? And I know you've been around for 10 years, but can you just give us kind of a high level startup, ongoing costs? And we can do the back of the envelope math for California. And then what are your sources of funding today?
That's a good question. I've been with CORHIO for about 5 years, but I know we started out of legislature here in the state of Colorado, and I can see Akko's like quickly Googling over there for me to try and find out how much money we started with.
Follow up.
I know that we had a very small budget to begin with, like in the $1 to $2 million range, I believe. And then have since grown that just with our partnerships. We get federal match to a lot of the state funding. And so we utilize that with our programs.
Do you use user fees for ongoing costs?
We do. We have user fees for notifications and for the Patient Care 360, the web-based portal. Yeah.
Thank you.
Mm-hmm. And a lot of those were offset by the state programs that we did to onboard.
And are you, just a question with, I think we spoke about this, but I don't remember it in my notes, with high tech sunsetting, do you still have a state program to help with that onboarding going forward?
We do. So we're currently going through the CMS certification process on the new MMIS funding source. And so that will be a 75-25 match.
And do you see a gap in that timeline, or are you able to just kind of move right into, you're going to keep kind of the same framework and then move into a different funding match?
Yeah, so a little bit different funding mechanism, like I said, but we've contracted quickly with the state to keep that in place. Fantastic.
One more question for Mark, and then I'll go over to Claudia. So Mark Elson asks, do health plans rely on CORHIO for HEDIS reporting at this point? Any other like comments on whether health plans are a client? Clearly the state is, but.
Yeah, so I did call out in the chat that we do currently have a few payers utilizing us for that supplemental data. We are actually looking to expand that and become NCQA data aggregator validation, or DAV certified, and we are looking to do that in 2022. So we're currently going through that and looking at that, looking forward to Contexture, and we imagine that we'll have many additional payers come on following that venture.
Terrific. And Claudia, I think you have your hand up.
Yeah, thank you. This was so interesting and helpful. My question, so we are really made a push through CalHOP to bring on ambulatory CCDA data, and we are DAV certified, so we've gone through that process. Here's the challenge we're facing. many of those practices don't have any IT capability and are using EHRs that also have very little capability. So when our plans come to us and say, hey, we're not always getting vitals, or, the NPI is missing, all of these data quality issues, it's like we really can't figure out where to push because the practice has no bandwidth or leverage. The vendor really isn't motivated. And we don't have any funding for that at all. Like when our practices don't pay us anything. And so we work with the vendor hubs. We work with Athena and Greenway and Practice Fusion. We do direct connections to Epic and Cerner and Meditech and others. And we work with a company called SmartLink that can go in and generate a CCDA. But those CCDAs are often not conformant. And we just go back to the plans and say they're not conformant, but really we can't figure out a scalable strategy to make them conformant. We have 1,500 sites today. We'll be expanding that to thousands more. So we'd love and we don't have any funding. Like it would be one thing if we had $10,000 per practice and could go in and do a bunch of coaching. We have no funding for that work. But so I'm curious what your advice would be about a scalable approach to improve data quality in light of all of those challenges. And maybe it's just like, welcome to our horrible world we all live in, but would love your thoughts.
I would say the primary way we are getting through that is we do have the money to provide the technical assistance. So the fights that we have with EHRs on how do we fix this, how do we do this, not throwing Athena under the bus, but they all have our practices that are connected on MU2 CCDs. And we just found that out because even when they took the upgrades for 2015 cert, they didn't upgrade their CCDs to the MU3, even though it's available. So now we're going to transform all of our Athena sites over to this MU3 architecture so that it has the better content that it has. But it is really just digging in and then finding a participant who's willing to make the effort. So like Athena, we definitely have a champion practice who says this isn't right, we want this to be better. And then they're pushing, and then they have the money behind them to say, hey, Athena, we need you to fix this because we're paying you. But CORHIO unfortunately doesn't have that buy-in, but we do have the funding to be providing that technical assistance. So I would say my recommendation would be see if you can get any funding and put the reasoning behind it.
Is that funding you're getting through the state?
Yeah, so for our APM program, practices are provided during their onboarding phase. They're provided monthly support. So we have onboarding funding that helps to cover that. And we try to catch as much as we can during the onboarding phase. And then on top of that, all of our active and onboarded practices get quarterly support. And so trying to tie in as many of those hours into that to improve that data.
So thank you. And I just am looking at the time. I know that we have other items to get to today, but I would welcome that we would love to do some follow-up. I know there's some additional questions in the chat that we weren't able to get to, but if that's okay, Heather, I'll follow up with you and the team and see if we can get those answers. And I would just I just thank you so much. We are definitely in the shadows of your success. And we would really hope to continue to learn and be able to bring to California. Hopefully we can not leapfrog you, but at least leapfrog ourselves and get there faster because of the paths that you've paid. So thank you so much for being here, and you're welcome to stay on for the remainder, or I know you're all busy. So.
Thanks so much for having us. And we'll also put our contact info in the chat in case you all have additional questions.
Fantastic. That'd be great. We'd love to. Okay, please do. So I'm going to just switch gears here. Robbie, are we joined?
Yeah, I think we're going to switch gears here. As Tony said, we know our CHHS Stakeholder Advisory Group is putting together a data sharing agreement subcommittee, and we thought it would be a good time to kind of revisit our conversation around TEFCA. we're also putting together a fact sheet on the CalDURSA, so stay tuned for that in our next weekly roundup. But we do have an esteemed guest today. We've got John Kansky on from Indiana Health Information Exchange, who's part of the HITAC committee with ONC and part of the a TEFCA co-chair. And we just wanted to bring in some folks and welcome, others to kind of chime in too around thoughts around how our stakeholder advisory group within Cal HHS should be thinking about incorporating TEFCA into this data exchange framework we're putting together. I think just to move forward 2 slides, if we could, Kira, these were some of the potential impacts and considerations that we've discussed here at our meetings before. How do we think about TEFCA as something that, is it duplicative of current efforts with national networks? What does it mean to have voluntary participation, and how might that affect, our data sharing mandate in California? How do we consider its, the limited kind of scope of use cases that might not meet all of our data sharing needs in California? And, I think most importantly too, how do we kind of fulfill the promise of real-time data sharing under the budget bill passed this summer, which ultimately won't be realized through TEFCA. So with all of that, John, thank you for joining us today and joining the conversation. I think, one thing we'd love to sort of hear from you is how, as someone who leads a statewide HIE, how do you kind of anticipate TEFCA affecting your work as a health data utility?
Sure. Thanks, Robbie. And I also see some old friends on the call. So hello to you guys. Hi, Devin. I prepared for this by reading the info sheet that CBH put out, which was really very good. So hopefully I've got some comments that are helpful for the road that you guys are headed down. And I'll keep it brief, and hopefully we can have some Q&A. First, I wanted to start with the disclaimers and caveats, as we often do. So as Robbie mentioned, I'm on the advisory committee for ONC. I co-chaired the TEFCA task force a while back, and I have some connections to Sequoia and the Ehealth exchange. So that's kind of where my TEFCA perspective is coming from. But the good news and bad news is that I don't work for the federal government. So the good news is that I can offer some opinions that you might not be able to get from a federal employee. The bad news is I might be inaccurate in some of my things. So put on your Kansky filter. If I say anything radical, you might check me on it. Go ahead.
Oh, no, sorry.
Yeah. Caveat number 2 is that there really is no TEFCA yet. So we all have to be in wait and see for now. That ends the caveats portion of the presentation. I mentioned the info sheet was really good. A couple of updates or comments that I wanted to make is that the exchange purposes list that they are now working with, it goes back to the original TEFCA 1 exchange purposes list that includes treatment, payment, operations, public health, benefits determination, and individual access. So that is comparatively new information and seemed pretty relevant to some of the decision making you were doing in terms of why California needed an additional thing. By the way, what do I call the California TEFCA that emerges from ABB or from AB 133? What's the vernacular?
Data exchange framework.
Okay, your
exchange framework, yeah.
Okay, great. So the other thing I wanted to comment on was timeline. Everyone's very interested in timeline, and we know that there will be a common agreement early next year, and I would expect some organizations to be prepared to sign it very quickly. and begin the process of apply to be QHINs. And so in one sense, TEFCA will be pushed off the dock in early next year. However, we don't know how long it's going to be before the QHINs are vetted and approved and go live. And they're kind of, they got an Alexander Graham Bell problem. If one person has a phone, who do you call? So they're going to need a cohort of QHINs to be able to actually move data. And then, so when does that happen? Well, we don't know. And then of course, how fast is the uptake of participation in this voluntary ecosystem? So if you have live QHINs, but there's a smattering of participants, how useful will that be? Kind of, Robbie, to your question about how IHI is preparing for this, one of the things we're very interested in, because we have participants that are across the spectrum of healthcare. Hospital systems are very important participants to us, as are large physician practices, and they all have EHR vendors that they are married to, and those EHR vendors are going to be giving them guidance on if and how to participate in TEFCA. And a little bit of, I'll probably caveat whenever I offer a Kansky opinion, which is clearly a Kansky opinion, this is one of those, none of those EHR vendors are going to be recommending that you call your local HIE for access to TEFCA. So one of the things I've been asking CIOs and CXOs at hospital systems is, please tell me when your EHR vendor is giving you guidance on TEFCA, and what are they recommending that you do? And so that would be something I would, especially for HIEs, to pay close attention to. So we don't know how fast we're going to have a real TEFCA and how fast participation is going to ramp up. That sort of gets into my next section, which I was calling HIE's role going forward, or in a post-TEFCA world, or however you want to view it. And the first thing I wanted to say is that I don't think HIE's purpose and role is going to radically change. And that's not naivete on my part. That's more like the HIE curmudgeon view, which is that, I mean, we've seen some TEFCA-like stuff come and go, and until it's real, it isn't real. And even if there's, 2 to 3 years in the future, it's really transformed the level of availability of information, or the way that information is available, then HIEs might be compelled to do things quite a bit differently. But until then, we have to carry our water. I mean, this is I'm getting on my soapbox a little bit, but we have a responsibility to serve our constituents with the services and the exchange that we do, and we cannot abandon our posts, so to speak. So stay tuned and keep an eye on TEFCA. The other thing that I've threatened to print this on a T-shirt, but interoperability is not one thing. And prior to the pandemic, Kansky opinion, the ONC and the industry was really focused on point of care data access, making sure that if a patient was being cared for here and that clinician needed access to that patient's data from over there, could they get it? And one of the things that the pandemic really shed light on was that was one very important use case of interoperability, but didn't really speak to public health or population health. And I don't just mean communicable diseases or the next pandemic, I mean population health within the healthcare system, or managing of chronic diseases, all those things we need information for. The TEFCA was designed in a pre-pandemic view, which had a significant focus on point of care data. That isn't all obviously that TEFCA is focusing on, but it's a primary focus. Let's see. That gets a little bit into, I'll stay off my soapbox, but you have to realize that as an HIE guy that's talking, but health information exchanges as health data utilities is one of our latest mantras in terms of trying to get state leadership and healthcare leadership and business leadership in our state to understand that there's so many needs for healthcare data at the patient and population level across the state that goes beyond just healthcare and public health. And we need to be able to serve as many of those functions as possible. What does that mean in a post-TEFCA world? That's where I say HIEs, or at least if you're a robust health data utility, your role shouldn't probably change a whole lot in a post-TEFCA world. You just have to figure out how to complement it and work within it. So does TEFCA make any of that easier or harder? Open question. Mainly right now, I'll be honest, my view on behalf of my own, selfishly on behalf of my own organization, is trying to make sure that there isn't a misunderstanding of what TEFCA will or won't accomplish for the healthcare system or for public health. The biggest thing I'm worried about battling is this is the other t-shirt I'm going to have printed. It's going to say and not or, meaning it's not do I participate in TEFCA or do I participate in the Indiana Health Information Exchange? It's yes. And we have to have a coherent explanation for why it's and not or, and we have to be ready to make sure that we educate people with that message. Some of the challenges that were noted, and then finally I'll close with a couple of pieces of opinions that you can take or leave in terms of California's data framework. One of the challenges with TEFCA is that it was designed with a sort of start over view of the interoperability ecosystem. It's a little bit too much, in my opinion. There could have been a view of, okay, what is the current ecosystem and what doesn't work with it, and how do we take a laser focus at those barriers and make it better. The TEFCA that we've got is a little bit more of a, let's design a, let's start let's just assume what we have doesn't work and design an ecosystem somewhat anew. Others on the call may disagree with that characterization. It is a bit of an oversimplification. The other challenge is that with TEFCA as we're rolling it out is that it compels exchange purposes that are going to disrupt the current ecosystem. And in other words, there's in the common agreement to be a participant in TEFCA, one will have to accept certain flow down terms of that agreement, which will ripple through the participation agreements of all the national networks as well as all the HIEs, and there will be certain compelled purposes. They're all great, they're all valuable, they're all honorable, but as anybody who works in health information exchange knows, your ecosystem is delicate, and telling participants that they have to allow their data to be used in new ways is not insignificant to those participants. Opinions that might be relevant for California is knowing what the goal of your California, I don't know what the goal of your California framework is, but make sure that that's clear to the people who are designing and making those decisions. You want to learn from the lessons of TEFCA, there was some implications in your. Don't try to. I would not encourage you to try to get out ahead of TEFCA. I would encourage you to study TEFCA and learn from it, and maybe above all, harmonize what you're doing with TEFCA, or at the very least, make sure that it is compatible with. You don't have to use TEFCA, but if you can I know there's some ideas that the California framework will be able to enable things like supporting behavioral health or social services organizations. Part of me, the HIE guy wants to say that you can use your existing HIE infrastructure for that and connect those HIEs into your framework and let the HIEs do what HIEs do. Sorry, we're running up on time, so I'll just close with that. Please, whatever you do, try not to build anything from scratch. Use what's existing. If TEFCA is going to be there regardless, because it's from the federal government, then learn about that and use it if it's useful.
I think that's great advice, John. And I know we're at time, but I do have just kind of one key question for you. So, the advisory group we have in the state, the charge is pretty broad in terms of coming up with a data exchange framework that, all organizations will need to agree to meet this data sharing mandate. We have a lot of white space in the state. So we do have some HIEs. We do have, folks who are on EHRs that are plugged into national networks, but we have some that aren't. And then we've also got, behavioral health and social services providers who aren't linked up either. What is your sort of, maybe if you had one recommendation for our state as we're moving down this path, kind of working from where we're at with this patchwork of infrastructure and connectivity, what would be your one kind of key suggestion for us just in general?
Yeah, don't have a patchwork.
Yeah.
I always have to remember when I'm talking to people from California that you're kind of like a separate country, and it's really hard to unify an entire California. But the less, two pieces, I guess, the more you can unify what you have, serve those white spaces with existing organizations. Existing HIEs should be able to expand into those white spaces. How do you get the white spaces to be willing to use the existing HIEs that you have? How do you get the existing HIEs to be as much of a cohesive patchwork? And then whatever you do, please don't try to create, we got a current ecosystem, we're gonna overlay a TEFCA ecosystem, you're gonna have a California framework. You gotta figure out a way to not to make that three things.
Mm-hmm. No, it's an excellent point. And I think folks have been pointing that out at some of our stakeholder meetings. So thank you so much for joining us and sharing your views on TEFCA. I think it's really great to have you as someone who's been really close to the development of TEFCA, and I think someone who can bring that HIE point of view as well in terms of how we kind of make sense of all of this, and especially as a state as we're creating our own sort of TEFCA, if you will. So really appreciate your time and thanks for joining us today. And we'll make sure to keep you posted on our California developments.
Great, much appreciated.
Yeah, thank you. And I also just want to acknowledge that we are a little bit past time, but I, in the spirit of John's parting words of, don't create things from scratch. I just think, Robbie, if we could go to the slide deck again, I just want to highlight the news blog piece and make sure everybody saw it or sees it. So there we go. Nope, there it is. So both Mark Savage and Devin McGraw were able to collaborate and have a blog post that points back to the California, this piece was done in 2010, Consumer and Patient Principles for Electronic Health Information Exchange. It really kind of harkened when we saw it, we brought it up on our last call, that it was still evergreen. It, I think, would really serve us well if the HIE Advisory Board were to look at it and adopt it. So those of you who are participating, please take a look at it. I'm going to send it over to John and Jonah and just let them know that, that this is here. In addition, we'll be, as staff, reaching out to those that signed on and endorsed this piece of work and let them know the education and all the work that we're doing as part of the coalition. So if you know anyone that you'd like to be able to pull in, or you worked with someone as part of this initiative, please let us know and we'll make sure that we do that outreach. Thank you, Nick, for putting in the blog post. Again, we're kind of coming to the end here. One other thing that I just would like to highlight for everyone is we are actively working with all of you different organizations to be able to contribute to guest blog posts as part of our 7 ingredients to HIE. So I look for continued pieces, and if you'd like to be able to contribute, maybe Nick, you could put the link to that blog post as well. Again, this is to highlight, let's not recreate the wheel. Let's make sure that we use what we have already working in California to be able to satisfy the pieces and parts that we need for the California data exchange. Robbie, did you want to also make some additional remarks?
One additional announcement, if we could just move to the policy briefing slide, Kira.
Okay.
Please register for our upcoming event. I don't want to forget that, Timmy. We've got an awesome lineup. I know we've got Katie on the call, Katie Hydorn with ITEP, who will be moderating. This will be on Friday, the 12th of November at 11 a.m. Please register, share with your networks. We will share out some social content that you can share as well. We'll put it out on our social content too. But we've got a great lineup with folks from plans and providers, startups, community benefit. So super exciting. I don't know, Katie, if you'd like to share anything about it.
No, other than I'm really excited to be a part of it, and can't wait to meet all of these amazing speakers. And you know, I was really inspired by the conversation today, so I had a very active chat going on. So just excited to continue the work, and please join us. It'll be a great conversation.
Excellent. Thank you, Katie, so much for your partnership and moderating the event.
And I want to just go quickly to our calendar of events. And there's a lot of other announcements in this deck, so please take a look at it at your leisure, as well as it'll be in our weekly roundup. So our next meeting, I just want to leave when our next meeting.
Our next meeting will be the 18th at 11. So we'll be skipping ahead a week. We'll give everyone a break next week. The 12th, please come to the briefing. The 18th, our next meeting. We'll take off time for Thanksgiving, and then we've got more meetings in December as well. And just some other ones to note, there's another TEFCA monthly call on the 16th of November, and ITEP is having a broadband policy forum on November 17th. So please make sure to check those out as well.
And Robbie, I think what we'll do is send out a calendar invite for our policy briefing for that week. So look for that in your calendar.
We'll be sending out a news blast as well today around the briefing, which you can share with your networks as well.
Any other additional comments or questions? Okay, everyone, thank you. What a great meeting. And you know, I think just know that we're not walking alone, and we have these fantastic colleagues that we can pull on. And you know, thank you, Claudia and others who were able to make those introductions for us. Keep them coming. All right, thank you.
Thanks, everyone.